Mr. Chairman, first of all, I want to say thank you very much for the honor to be here. It's really an honor for me after working so many years in interventional cardiology, and recently, the last 3 to 4 years, I worked in the Maastricht area. And the subject of today is just in between cardiology and cardiothoracic surgery. What you see here is a famous picture of Rembrandt. Rembrandt made this picture in around 1630, and one of the leaders in this picture of doctors is Nicholas Tulp. 10 generations later, I can tell you that his grandson is now an orthopedic surgeon, and he is doing very well on the bicycle, and he's a good friend of mine. So doctors come together and trying to learn from things is from a long, long time ago already. And I think even before that time that Rembrandt made this painting, doctors have been interested to share their opinions and share their thoughts and trying to cooperate in difficult situations. Well, it's my task today to tell you a little bit about the ideas in the Maastricht area, but I think also in the Dutch area about heart team. Is it evidence-based medicine or still expert opinion? For the first time, heart team came into the guidelines in 2004, and it was defined as a regular meetings with the cardiac surgeons to discuss indications for interventional cardiology, cardiac surgery, or medical therapy to reach a formal written therapeutic decision, and are necessary for all non-acute patients with a copy, a letter, to the referring cardiologist or home physician. But you have to take into account that this is a real class 1C indication. What does that mean? That means everybody likes it, but we don't have any evidence. That's the point. So it's in all guidelines, but without evidence. So we have to think about guidelines, and guidelines are more or less the expert opinions of all sorts of ad hoc heart teams. Anyway, to become a lecturer, invite lecturer here to be 35 years in cardiology, that means the way to make heart teams popular. Anyway, heart teams are not meant to innovate. Heart teams are meant to evaluate a patient in terms of what we know and what's sure. And heart team must be very careful to prevent innovation, because the real innovation, as we see here, a nice example, was made by people like Andreas Grunzig or Favorolo, who made the first bypasses. And as a matter of fact, you can see on this picture, also very interesting, what Andreas Grunzig did. He was more or less in his first publication on PCI treating a proximal left main disease, which is still a subject of a lot of discussion, how to treat. So the existence of a heart team is not always a condition, and sometimes even preventive of real progress. We have to keep that in mind. Well, in the Maastricht area at this moment we have several heart teams. On daily basis is the heart team on coronary artery disease. It makes decisions between the 3 main options: bypass surgery, PCI, or conservative treatment. But we have also dedicated teams for aortic valve treatment or mitral treatment. We have congenital heart meetings once a month. We have on weekly basis ablation and device heart teams. We have complex heart teams on Friday in conjunction with the hospitals around us. And above that we have still grand round and multidisciplinary teams like the intensive care discussion. So a lot of teams, a lot of effort is made, but we don't have to forget that the patient still should be in the center of all the things that we're doing. Thanks to the American colleagues, we have a nice schemes of how to treat people. From the literature that is known, we have this very interesting form. You don't have to read this all, because this is just a scheme that you can use during your heart team. But you have to keep in mind that not every patient is fitting into this small rectangular, as you see. This is a kind of rectangular thinking, which is quite good for constructing your thinking, but there's not always a rectangle every patient fits in. Let's look to the practice of all day. You see a large variation in this moment in between the use of PCI. It's about 500 or more in Germany, and Belgium is also very high, even higher than the United States. And we have some countries which only 100 patients per 100,000. And the surgery, and the same on the left side, the red bars are quite different over the different countries. Also, when you look to the US, you see that the use of bypass surgery or PCI, on the left side is PCI and the right side is surgery, can differ a lot in between states. What's in a regular heart team now more or less the outcome? This is an article that's written by Pavlidis, and it reflects the experience of the British people in London and the Thompson Hospital, Westminster. And this is a complex heart team. This is 400 cases, patients in 51 heart teams in a large tertiary center. So that means only the complex cases are discussed here. And you see the measure. It's in around 122 patients, and it's treated by conservative management. 105 it's bypass, 56 it's PCI, and so on, a little bit less. So what you see is that at least in 14 patients we need repeat angiography. And also a heart team is involved in making decisions about patients recruiting for trials as well. If you look to the patients who come again to the heart team, then you see that the reason for not implementing the heart team decision is mainly caused by the comorbidity and the patient's preference, as well as symptoms didn't seem so serious as it seemed. So in 29 patients, that's in around 20% of the cases of this heart team, there came another discussion on second chance. Bonsol in Fulda Clinic in Germany gathered about 12,000 catheterizations in 5 years. And what he saw is that only 22% was taken to the heart team. That's about 2,408 patients. That's about 22%. And of those group, 2,061 went to surgery. So the heart team, in his situation, was used more or less to sell the patient to the surgeon. About 80 to 90% of all the PCIs was not discussed at all in the heart team. And that was the conclusion of his article, that having a nice group of first presentation of coronary arteries each is very difficult if you don't present the patient to the heart team. This is a very difficult slide. This is a slide of Pereira, who published the Massey trial. And what the trial was, that the trial randomized in between PCI, bypass surgery, and medical treatment. And before that randomization in triple vessel disease, 2 doctors were asked to give their opinion how the patient should be treated. And what you can see in the middle white things is that the numbers are quite reasonable, but if you have a randomization to PCI and the doctors advised PCI, the probability of survival was 84.9%. But if the randomization to PCI was PCI, and the doctors referred medical treatment, the survival was only 69.8. That means the doctors weren't so bad at all. So this was an article for Pereira, an argument to value quite a lot the influence of heart team doctors. What's the problem in the data we use to make the right decisions? There can be a lot. First of all, the generalizability. For instance, if you use syntax data, you have to keep in mind that of about the 4,000 people who were eligible, more than 1,262 patients were not taken into consideration, but they were taken out by a heart team decision. So at the end, only 1,800 were randomized. That means that although the statistics are perfect, the generalizability is too short. What we know is that the observer variability is in between 60 and 80% most of the time, but sometimes in between 40 and 60. That means the intra-observer and the inter-observer variability is too big. We have to improve this. Is there enough evidence-based medicine at this moment? In up-to-date for single proximal LED lesions in complex disease, the trials have been done many, many years ago. So up-to-date is starting, there's no evidence at this moment. Greenbaum is telling us the same. And the only trial that we know at this moment, the most recent trial, is only 1, 2, 3 patients, and that's in 2000s. And that shows less complications with surgery than with PCI. And all over the world, PCI now is probably performed in such type of patient as the first choice. So we're not using always evidence-based medicine. Also, the other hand, this is a nice graph of survival after surgery. We have to realize that even if you operate an octogenarian, that's this last graph, in 50% of the people are still alive after 5 years. So surgeons are not always doing a bad thing, even when you have a complex situation. If you're not treating the patient according to the guidelines, and that's what this article from the Belgian group is that in 600 patients with the aortic valve disease and triple vessel disease, you see that the option bypass surgery plus valve surgery is the best option, that's the upper. But if you only do valve surgery, it's a little bit less. But if you only do PCI, it's even worse, but much, much better than medical therapy. So in heart team decisions, you should consider as well less optimal decisions, but sometimes easier to perform and with also some benefit of the patient. There can be a lot of factors that influence non-heart team referral and decision making, like building an empire or conflict of interest with industries, knowledge of the patient preferences, no appreciation of personal therapeutic limits, not being up to date regarding PCI and bypass surgery indications, opportunity to include patient in a randomized trial, physician-patient bonding, personal conflict, a lot of things that can happen if there's not a heart team involved. And only your personal interest and your personal opinion decides. As a heart team, there's also a task to formulate consensus for non-heart team situations. In acute PCI for infarct, we know that the operator has to decide on his own. And the heart team can help to discuss afterwards with a group of patients how to handle. For instance, in acute MI, it's better to do single vessel versus acute PCI should be the default strategy. An acute multivessel PCI can only be justified in hemodynamically unstable patients with multiple Truly lesions. And significant lesions of the non-culprit arteries should be treated either medically or by staged revascularization procedures. Both options are currently acceptable. But the role of the heart team is to make a binding factor in between the opinions of all the interventionalists and to try to make one nice and clear politics about this issue. The same is about diagnostics. I will skip this slide more or less. What are the possible study designs to validate and evaluate? We can explore the reproducibility of heart teams. We have to do it. We have to assess the change in treatment recommendations. We can cluster randomized trial in which centers evaluate patients either in a heart team or according to the original referral patterns by the surgeon or cardiologist. And the most beautiful one, in my opinion, is before and after study to compare treatment decisions and outcomes before and after implementation of a heart team. And the last one, comparison of treatment decisions and outcomes of different centers with and without heart team evaluation. So my takeaway message and my last slide of today will be the heart team from class 1C to class 1A. In the heart team, not every patient should be discussed. Only semi-complex patients, well prepared. Imaging authority is warranted. Use video conferencing for referring centers. Other specialists on demand. Schedule experienced participants, don't send the younger staff. Establish continuous quality monitoring by sampling that will be judged by different heart teams and compare the results. We need outcome databases to know how your production is, how your results are, and how your outcome is compared to others. In the heart team, prevent a guideline battle. It should be a non-autocratic setting and help to develop local consensus on issues adjunct to the guidelines. For that reason, I think the patient will be helped by a heart team consisting of both surgeons and both cardiologists. Thank you very much.